Hi, my name is Dr. Verma, and I'm here to discuss international volunteerism, my experiences, and some of the benefits of doing international work in spine surgery. I want to go over my experience, some of the pros and cons of international work, testimonials from other surgeons that I've worked with, whether or not international volunteerism should be included as a component within a residency, and some resources that you can look to if you're interested in this kind of work. My first experience was in a medical school, as a medical student, rather. I went to the Dominican Republic in 2009, and you can see some of the conditions in which we worked with. Even though the conditions weren't great, the experience was amazing as far as collaboration, working with other surgeons, teaching, and providing the same quality of care that we do in the United States. And that early experience, both in the Dominican Republic and in Ghana, really solidified my interest in scoliosis and in outreach. And I think really shaped my career to be one where I really wanted to do this kind of work long term. And part of my interest as a clinician is to inspire other surgeons to take on this kind of work because of the values, how valuable it is in terms of building your career and how rewarding it is personally. In this picture right here, I was a medical student on this mission trip in Ghana, and some of the people in this picture are very prominent spine surgeons, and they've moved from different institutions, and it really allowed me to make friendships early on with people that were pretty skilled in scoliosis surgery, and that was an important benefit for me early on. On the right, you see Professor Boachi, who started the Foundation for Orthopedics and Complex Spine in Ghana, and he ultimately retired from his practice at HSS and now is in Ghana full-time doing complex pediatric spine surgery. My experience in Ghana, this is an example, where there were 5 surgeons, which included senior surgeons and trainees, 2 anesthesia personnel, neuromonitoring, an implant technician, as well as an ICU team and some nurses, physical therapists. Maybe the total staff was 22 on a given week, and we would shoot to complete 16 to 20 cases. And the days were long, and the cases were tough. This is a pretty typical example of the type of pathology that we would see there, is untreated scoliosis that largely had led to curves that were over 90 or 100 degrees, very stiff, very imbalanced in both the coronal and sagittal planes, and would cause great dysfunction. And when the curves get this big, they start to cause pulmonary problems as well. And they tend to be progressive in nature, and if you don't treat the scoliosis, probably will lead to a shortened mortality. And when we lay the patients down on the operating table, you can get a sense of how complex the case is and how difficult it would be to correct the deformity and stabilize the curve. This is a picture intraoperatively. In this picture, you can see that we have a temporary rod that's stabilizing the spine. There are posterior elements posterior to the spinal cord that are keeping the spine somewhat in place. And then ventrally, anterior to the spinal cord, we're dissecting away the bone. And you see the spinal cord in the middle there. It's completely dissected free. And just anterior to the spinal cord and anterior to all that bone that we've removed is the aorta and the contents of the chest cavity. So the surgery can be very technically difficult. And one of the important things is when you do this type of surgery is to correct the deformity in a slow and controlled way. And only do this in specialized centers. Our first day was generally clinic. We'd see 40 to 60 patients. We'd work together as a team. And after clinic, we would go over all the cases and have dinner as a team and discuss the cases. This is me as a medical student, helping out in any way that I could as a medical student, which involved rounding on patients and talking to patients and gathering data for the surgeries, but also scrub in on cases and observe and learn. The days were long. This is one of the senior surgeons in Ghana, and you can see he's sneaking in a nap between his first and second case, and I think it's pretty late there already. And then I became so influenced by this experience that I chose to go back to Ghana in 2013, and actually I went back again in 2014 15. And I even wrote a little article as a medical student for our medical school newspaper. And my job as a resident was largely to organize the patients, organize their rounding and patient care on the floor. And this is a typical example of something I did while I was there. And we did some pretty complex cases. This is a case where a patient had Pott's disease, or basically a deformity in the spine that developed after tuberculosis. And in order to correct the deformity and stabilize the spine neurologically, it required a 3-level vertebral column resection, which was done with an all-posterior approach. And on the image on the right, you can see that 3 screws on each side were placed above and below the area where vertebral column was placed, and a harms cage or a titanium mesh cage is placed in the anterior column to provide additional support. And unfortunately, just like there can be complications in the United States, there can be complications abroad. It's important that you identify the problems and that you treat them appropriately. This patient on the left, you see, had a displacement of their cage and had to have a revision surgery where the cage was placed again in the correct position. Amazingly, this is that same patient only days after having a multi-level vertebral column resection. And this speaks to why I think pediatrics, especially pediatric spine, is so amazing, is that kids have an amazing ability to recover from very difficult surgeries and maintain a positivity that's really infectious. So this is a kid only a few days after a major surgery. He's singing and playing with his friend, and he's up and walking around. And this is the hospital environment in Africa where I've done previous work. And you can see it's a very pretty hospital where I've done some of the work. And it's designed in a way where the physical therapy, the cafeteria, the hospital, the OR, and the administration is all linked together in a very cohesive way, so that when you come into the hospital to operate as a surgeon, you are immersed in the patient care experience, which is a very unique experience and very gratifying as well. And my personal interest in outreach is also to build an infrastructure for research. Much of the research we do is done in the United States, and there's an incredible opportunity to do research abroad. And I've done several manuscripts looking at pretty simple research topics and projects that were done primarily abroad. The first paper there was done in the United States, and then we mimicked that paper in Ghana, and then again in India, utilizing the SRS-22 to collect normative data on scoliosis. And so my main interest is in inspiring other surgeons to take on this kind of work and do research internationally, because it's really an area that hasn't been explored. And it's a lot of fun. This is me playing with 2 kids that I met on the beach that largely weren't involved with the hospital in any way, but they're so friendly and they're so interested in why you're coming to visit their countries. I found it to be very rewarding. And here I am back in 2016, volunteering again, this time as a surgeon, an attending surgeon, and this was our one of the days of clinic. And clinic can be a lot of fun because you'll have a bus of 30 kids that show up all at once, and they're energetic and wanting to play, and you have to see them quickly and triage them and identify the patients that probably need surgery in the near future. I've shifted my attention in recent years to the global spine outreach. As an attending physician, it became a little bit harder to travel to Africa twice a year. So I worked with this other group, the Global Spine Outreach, which is based primarily in Cali, Colombia, although they have outreach sites in Chihuahua and Monterey. And it works in a model very similar to the Focus Hospital in Ghana. And again, the experience is incredibly rewarding, and I encourage anybody that's interested in outreach and spine to get interested in the Global Spine Outreach group. The 2 main founders are Tony Ranella, who's been going to Cali, Colombia for many years, as well as Greg Mundis, who's become more recently involved and is really spearheading a lot of the research. And Juan Uribe in Cali, Colombia is one of the other lead surgeons that helps build the relationship between the Colombian surgeons and the American surgeons, so that there's a fostering of education there that can go on long term. And it takes a lot of people to get one of these trips underway, so special thanks to the volunteers and the administrators that help organize these trips. And here you see we have the teddy bears for the kids. These teddy bears are unique because there's actually an x-ray that comes with the teddy bear that shows the teddy bear has scoliosis surgery just like the kids did. So it can be pretty rewarding. For me, I found the trip to be most gratifying because of the educational opportunities, the opportunity for me to learn and expand my skills, and also the opportunity to teach other surgeons that are there. And here you see me in clinic. You see the medical student is taking notes based off the exam in clinic. And you see in the operating room between cases, we often take time to teach and explain our thinking and surgical plan on our patients. And here I am in the operating room working on a case with a fellow. The surgical part of it is very small, but the gratification you receive and how happy it makes you when you come home is really the true reward. This last trip, several of us were even saying, this is better than vacation. That going on these trips is more rejuvenating than going on vacation. This is a video, I think, of me doing some teaching in the operating room. I believe this was a growing rod case. We were discussing some of the technical aspects of putting in a growing rod construct in a pediatric patient. And then this is a video in surgery, and you can see that even in surgery we take time to do a lot of teaching, both for the local surgeons there as well as medical students and visiting surgeons and fellows. And every step of the case is an opportunity to teach. To me, that's one of the main values of doing the outreach work is clinical care, gratification, academic opportunities, really building up a system. In the 15 years that I think they've been going to Cali, Colombia, we've only been going for 2. But there's been an incredible gain of knowledge at that site, and they've become incredibly skilled in doing very complex spine surgeries. This is another case that was done. Again, this was done for TB kyphosis and Pott's disease. You can see there's an incredible deformity on the left side and an inability to stand up straight. The only way to correct this 120-degree deformity is with a multi-level vertebral column resection, which was performed with a 2-surgeon approach, and you see on the right achieved excellent correction and a stable construct. So what I think I gained from these experiences is motivation to pursue my clinical career at home, mentorship and friendship with other surgeons from different areas of the country as well as from other countries. I think perspective in terms of what we have in the United States in terms of medical care, how to improve it, how to make it more cost effective. And on a personal level, it makes you happier. And I think it makes you more gratified to do what you do. On top of that, I think you make some friends and you take a lot of pictures. Here's some statistics that can be helpful if you're interested in this kind of work. 80% of the world's population live in developing countries, yet 80% of orthopedic surgeons live in developed nations. In Ghana, for instance, there's on average 1 orthopedic surgeon per 1 million people. This is Professor Boachi, who really helped build up the focus site in Ghana, and you can see he's got a team of people that he works with in Ghana to help keep the foundation going. And the goal is to identify interested orthopedic and neurosurgeons in Ghana so you can train them. And that's really the goal of outreach, is not just to do these cases abroad, but really to build up a site and transfer the knowledge to another country so that these sites can eventually become self-sustaining. And one of the surgeons that I trained with in fellowship, Shane Birch, said, you learn to do surgery without all the fancy tools. And at the end of the case, we all had to clean the trays. So you really come to appreciate that when you open a tool, it's one you really need. And you don't open many, many trays because it creates a lot of waste and there's a lot of time needed to clean these trays. He also told me that he started 2 years ago as a volunteer and now he leads a team every year. And he tells me it's a lot of work, but it's also a lot of fun. And one of the admins told me that he comes back to work much happier. One of my old mentors from medical school and residency said the Ghanaian surgeons are eager to advance their knowledge and are appreciative. Time spent volunteering is also a personal learning and advancement. And he says that the experience is valuable for young and experienced surgeons. And this is a picture of actually a surgeon on the right who did total hip surgery internationally. And he was a very stoic surgeon where I trained. When I showed this picture of him in our residency, almost no one could recognize him because he's so happy with what he was doing. And that really speaks to the power of these experiences and how happy they can make you. He tells me, Dr. Hozak, that he felt in his heart it was the right thing to do, and it's a worthwhile addition to a residency or a fellowship, and then it gives you perspective that you have it pretty good here. And I would echo a lot of these sentiments from my own experience. Some of the cons of going abroad are the cost, time away, potential for illness, potential for complications and how these are dealt with. We can speak a bit about how complications should be dealt with in an outreach setting. And then also it takes away from family time. So some of these surgeons will bring their family members abroad, bring their kids as a way to teach them. Also to mitigate the cost and time away. Often surgeons will work harder the weeks before or the weeks after. I think it's important to go with an institution that has a very good infrastructure for outreach, where there's a culture of teaching and education, as well as other surgeons locally that can help manage complications that are inevitable when doing complex spine surgery. I think the 1 week cost for a resident is around $3,000 to $6,000. The income lost is variable for an attending surgeon. In an academic setting, it may not be anything significant. In a private setting, it could be much higher. But these are often offset by building your reputation, improving your surgical skill set, and opportunities for research and career advancement. And this has really become something that's been explored through the academy. There's been, in the academy, there's been recent podium talks and conferences about this, about whether or not volunteerism should be viewed as a core competency in residency and fellowship training. And my personal opinion is that it should. And there's growing interest. In medical school in 1990, 13.8% of students had experience abroad. And only 12 years later, that number more than doubled. And in the American College of Surgeons, 92% are interested in outreach work. And among orthopedic residents, 84% are interested in outreach work. Yet only, I think, less than 10% of residencies have an organized outreach research or outreach clinical elective. And if you look at international volunteerism in orthopedics and you do a literature search, there's only 24 articles on the topic. And this article looks at what percentage of residents went abroad and how often they went with members of their own department. And it was more than 50% that tended to go with faculty in their own department. So it's really important that attending surgeons make the push to do outreach work and get residents and medical students involved. And if you look at the distribution, I'm sorry to say a very small number of surgeons, spine surgeons, go abroad, but there's a lot more trauma and pediatrics and general orthopedics that's done abroad. So there's a real need for spine surgery to be performed abroad and for education to be dispersed in an international setting. And in another article, volunteerism should be brought to the forefront of residency training. And in the earthquake in Haiti, that was a very eye-opening experience because there were a lot of volunteers but not a very good infrastructure for actually helping people down there. So that they had hundreds of volunteers and orthopedic surgeons without supplies or infrastructure. And providing orthopedic care to the less fortunate is an ethical and a professional duty. In another study, this one looked at a survey, and they found that international health electives and orthopedic surgery training had a long-term effect. They looked at this one program. They found that 73 out of 154 programs had some sort of a broad program. Many of them were partnered programs. Often they were 2 weeks or 4-week electives. Some of the barriers to not doing international work were that the residents needed to organize it on their own. There was no time, there was no funding. But very rarely was there thought to be no interest. The interest is definitely there. And to date, only 10% of residencies offer a structured international elective. And the perceived barriers are financial and faculty support. But the actual barriers are probably the opposite. They're more related to safety and infrastructure and less related to money. And I found that if you have an interest in doing outreach work, it really takes a very small amount of fundraising effort to get this type of work on the road. There's one article from UCSF that is pretty influential that looked at the experience of volunteerism in the long term, and they found that volunteerism fostered a spirit to enhance surgical skills and decision making with a unique experience. And they looked at residents that had done an outreach elective and those that didn't. And the residents that had done an outreach elective were 3 times as likely to continue volunteerism long term in their career as opposed to the residents that hadn't done outreach work as in residency. And they were 2 times as likely to have a commitment to the underserved population as opposed to residents that hadn't done that kind of work. And this particular rotation at UCSF is organized in the R4 year with a total of 4 weeks abroad, and over 75% of residents participate. Some of the challenges of setting up an outreach elective are supervision, mentorship, cost. Often this requires resident fundraising, often industry support, departmental support, and perhaps even scholarship. Whether or not this needs to be an accredited portion of the residency or not is up for debate. And what the correct timing is to do these types of outreach activities is debatable. I went as an R3 resident, as a medical student, at the end of my fellowship, and then 3 times as an attending. But it's still debatable whether the ideal time to go is as a chief resident, as an R3, when you're still deciding on your surgical subspecialty, or perhaps as an R4. And I think whatever is decided, the outreach trip should be a mix of vacation and service. Meaning it should be some vacation time from the residency and some time given from the department. So I think overall what's needed is desire. It takes about 8 to 12 months of planning to plan your first outreach trip and link up with an organization. Depending on where you're going, you may need several vaccinations. You have to do your homework on the agency. If it's your first trip, you may want a mentor to go with you. If you're a senior surgeon, you may want to bring a young person with you. And you also need to have the buy-in from your family. If you've got little kids at home or other challenges, that can be difficult. These are the agencies that I think do great work. Doctors Without Borders, Orthopedic Overseas. In trauma and tumor, there's Global Orthopedics. If you go to the Scoliosis Research Society website, there's opportunities to look at the outreach groups that are supported by the SRS. I've worked with the Butterfly Foundation, the Complex Spine Focus Hospital. I've also worked with Global Spine Outreach, and I understand that other people have worked with Foundation for Orthopedics, Spine Hope, and there's many, many other good, reputable groups. And as a side bonus, my wife is also interested in outreach, and I think she built some of her interest learning off my experience. So it really can be an infectious thing. She's traveled to Uganda and Botswana in her residency, and she's found it to be an excellent experience. So key points summarizing, I think it feels good, it's energizing, there's opportunities for mentorship, education, and research. It's addictive. I'm going back to, this talk is a bit old, but at the time that I gave it, I was going to Ghana, and now I'm going back to Monterey and Cali, Colombia in 2018, and I'm really looking to get other surgeons involved in this kind of work. And everyone I've spoken to keeps going despite the challenges, so it really speaks to the benefit of the experience. And take good pictures. Thank you.